Bueno, ahora tenemos un video respecto al el examen de pares craneales.
The most primitive of our special sensory senses. The ability to sense and move along a chemical gradient is possessed even by single-celled animals. It also is unique in the way it communicates with the rest of the brain. It communicates directly with the limbic system, projects right to that emotional part of your brain, which is the reason why smells are very evocative of entire scenes and emotional experiences. So it's a very important nerve to test. It also is important because loss of smell may be a very early sign of both Parkinson's disease and of Alzheimer-type dementia. So the loss of smell is important to detect and check the smell. So I'd like you to close your right nostril
Uno de
and
los sistemas más antiguos, ¿no?
sniff.
El más antiguo.
Sniff in. What do you smell? Coffee. Very good. So coffee is familiar to most people, and so it's a good one to test. Please close your left nostril and sniff again. And what do you smell now?
Garlic.
That's garlic. Okay, so another strong smell. It's important not to use smells of irritating things, so things like alcohol, things that might irritate the mucosa. People will know that they're sensing something, but the irritant itself will give you a reflex response that actually covers up the true olfactory response. So don't be a 2 through 12 person, always check the first cranial nerve. No, we won't.
Segundo nervio. Recuerden que el primer y segundo nervio más que nervios son profusiones del mismo cerebro, ¿no?
The second cranial nerve, or optic nerve, is the major special sensory nerve of vision. It also forms a very important part of the reflex arcs that drive the motor portion of the third cranial nerve that innervates the iris and causes pupillary constriction. So when we examine the second cranial nerve, we want to make an assessment of vision. We want to make an assessment of the afferent component of those arcs. And then we also want to look at the optic fundus, to look right at the optic disc, which is the nerve head as it enters the globe of the eye, to see if there's any abnormalities of the nerve disc. Is it pale? Is it cupped? Is it elevated? Things that will give us a direct sense of any injury to the nerve itself. First place we'll start is checking vision. Remember, vision also requires proper refraction, and therefore vision can be abnormal, not only due to abnormalities in the retina, but abnormalities anteriorly in the eye, in the lens or cornea. To check vision, it's useful to have a small vision card. We ask the patient to cover one eye at a time. Hold this about 14 inches in front of his face and read the smallest numbers that you can off this. So cover your left eye. 8594037. Good. It's 20/20. So cover the right eye and repeat. 8594037. Good. And you can use numbers or letters on this. At the bottom, there's a series of black dots that help you to estimate pupillary size. So that's the vision component. Next, we're going to check the ability to sense light and send messages to the brainstem, which will then drive the third motor component of the third cranial nerve. To do this, we're going to shine bright light in each eye. Remember that the brainstem averages the light coming into the eye, so that the pupils are the same size on either side, regardless of whether light is shining brightly in one eye or the other. We'll check to see that they respond appropriately. We're also looking for what's called a relative afferent pupillary defect. What this would be is if we get less pupillary constriction with the bright light in one eye than the other, it suggests that the eye with the less pupillary constriction, driving the less pupillary constriction, has an afferent problem. It's not sending as strong a retinal message to the brainstem as the other eye. So I'm going to move across him. And we're going to start just demonstrating normal pupillary constriction. So if you can just look straight ahead of yourself. We'll start in the right eye. Get nice brisk constriction of the pupil. Left eye. Again, nice brisk constriction. You may occasionally see the
Como pueden ver, lo
iris
ponen
bounce
por
a
un
little bit.
costado,
That's called
no de
hippus, and
frente,
it's
sino por
perfectly
un
normal.
costado.
To check for that relative afferent pupillary defect, we're now going to do the swinging light test. This involves shining the light first in the right eye, taking it away, shining it in the left eye, always looking at the right eye, and then we repeat that, shining again in right and left while looking at the left eye to make sure that the pupil constricts the same amount when the light is shined in one eye and then the other. So, swinging light test. Here's the right eye, and I'm going to look just at the right eye. Nice constriction, let it dilate. Left eye, nice constriction. Again, dilate. Now I'm going to go back to the right eye, but now I'm going to watch the left eye. We get constriction. Dilates again. Now the left eye.
Están evaluando el reflejo
And
consensual.
again we get constriction. So we can see
Y
that
ahí lo que evalúas
the
es la
iris
bandileta media,
contracts
¿no?
equally, whether the light's in the right eye or the left eye, and this shows the absence of a relative afferent pupillary defect. The last part of the examination of the optic nerve is the exam of the optic nerve head and the fundus. Remember, the optic nerve enters the globe a little bit nasally and inferiorly. So your axis of vision when you're looking in should be in that way, looking down and inward so that you can come right in on the optic nerve head and avoid the fovea, which will cause some reflex withdrawal from the patient because of the very bright light. I want you to look about right here. I'm going to get up, come in, and right down on the nerve head. When you look for elevation of the nerve head, you can examine the arteries in the vein as they move out onto the retina. So,
A veces para
examination of
ayudarse
the
los
optic nerve
oftalmólogos
head, very
utilizan
important
unas
part
gotas
of
que
finishing off the
producen una
examination
dilatación
of the
pupilar,
special
¿no?
sensory nerve of vision, the optic nerve, cranial nerve number 2. We're now going to check the extraocular motions. This involves the motor components of cranial nerve 3, cranial nerve 4, and cranial nerve 6. We also checked the motor component of cranial nerve 3 when we saw pupillary constriction in response to light being shined in each eye when we were checking the optic nerve. It's very important to understand the motions of the eyes, that understand the anatomy and how the globe sits in the orbits and the alignment of each of the extraocular muscles with the axis of gaze. The 6 cardinal phases of gaze are designed in order to align the axis of the muscles with the axis of vision so that we can isolate individually the movement of each of the individual muscles. For instance, when I have the patient look to the right side, he's contracting the lateral rectus in the right eye, innervated by cranial nerve 6, and he's contracting the medial rectus on the left eye, which is innervated by cranial nerve 3. That coordination of vision is transmitted up and down in the brainstem between the nuclei by the medial longitudinal fascicula. So the ability to have conjugate gaze in all phases involves not just that the muscles work properly, but the coordination of gaze is intact through that fascicle in the brainstem. So we'll next just move the eyes through the 6 cardinal phases of gaze. So look right here at my finger, move to the right, up and out on the other side, straight to the left,
Eso se llaman las
down
ducciones.
and out,
Las
and down.
ducciones.
So those 6
Está
motions,
representado con un
laterally
cuadradito
on
en
each side, up and out,
examen.
down and out, are the 6 cardinal positions of gaze that isolate the individual extraocular muscles and allow us to detect weakness of one or the other in isolation.
Lo que han visto son las ducciones.
Cranial nerve 5 is the trigeminal nerve. It's the largest of the cranial nerves, and it has both sensory and motor components. The sensory components provide sensation to the face and anterior portion of the scalp, as well as the interior of the mouth, including the anterior 2/3 of the tongue. The motor component goes to the muscles of mastication, including the temporalis, the masseter muscle, and the pterygoids. So we'll start by checking the three divisions of the sensory component. And that superior division runs from the angle of the eye towards the ear, right up to about the top of the scalp.
No confunda, ¿no? La
The middle
sensibilidad,
division runs from the angle of the mouth and the angle of the eye back
dolor de la
towards
lengua,
the ear, and the inferior division
va
from
por
the
el
angle of
quinto,
the mouth.
el sabor es lo que va por el
You want to
sexto,
test each one
por
of
el séptimo,
those
perdón, por el séptimo
individually.
vez.
You do that very easily,
O
but
sea, si
just
se
finger
pellizca la
touch
lengua,
and
el dolor va
compare
por el
right to
quinto.
left to see if there's any asymmetry.
Pero si sienten un sabor, eso va por el
Tell me if
séptimo.
these feel the
Séptimo
same
vez,
or different.
intermedio de whisper, ¿no?
Here? Okay. So just gentle touch will allow you to test the sensory component. The trigeminal nerve is associated with a couple of very important pain syndromes. Tic-douloureux, which is trigeminal neuralgia, will involve one of the branches of the trigeminal nerve, most commonly the third or lower division. It's very painful, lancinating pain. The other pain syndrome associated with trigeminal nerve is migraine. The entire head is innervated by both the trigeminal nerve and then cervical roots 1 and 2. Those cervical roots and the trigeminal nerve come together, what's called the cervico-trigeminal complex. That's felt to be the area from which migraine originates, and so migraine will be felt in the distribution of these nerves. It's important also to recognize that the fifth cranial nerve provides the sensation from the inside of the calvarium, so structures of the meninges will also sense pain through the trigeminal nerve. To check the motor components of the nerve, we'll have him grit his teeth down very tight, relax, grit again. Okay, and we can feel the contraction of the temporalis and grit down again, relax, grit again, relax. And you feel the masseter muscle contract and relax symmetrically. The pterygoid muscles are on the inside of the mouth, and they also help close the jaw, but they also can pull the jaw one way or the other. So if on jaw opening and closing you see the jaw move to one side or the other, it suggests weakness of one of the pterygoids. Generally, the jaw will move away from the weak muscle. So open your mouth, close down, good. So nice symmetrical jaw opening and closing. So that's the examination of the trigeminal nerve, the fifth cranial nerve.
El complicado nervio séptimo.
Cranial nerve 7 is the facial nerve. It has both sensory and motor components. The sensory component is taste on the anterior two-thirds of the tongue. I don't routinely check that. You can check that with salty taste, bitter taste, sweet taste. The motor component of cranial nerve 7 innervates the muscles of the face, including the forehead, the cheeks, and the circular muscles around the mouth and the eye. So let's check the muscles of the face. First of all, we just ask the patient to move his eyebrows up. And you see the normal wrinkling here of the forehead, nice and symmetrical. Ask him to frown. Okay, and we get nice wrinkling here of the glabella. And I want him to close his eyes tightly, very tightly, hold them tight. Okay, so cranial nerve 7 again closes the eyes. There's circular muscles around the eyes and the mouth that protects them. I want you to purse your lips like you're whistling. Okay, show me your teeth. Okay, nice symmetrical contraction, nice nasolabial folds, relax. In repose, it's important to look at the symmetry of the face. This will be a subtle sign of people who've had previous strokes. Remember that cranial nerve 7 has bilateral innervation of the forehead from the upper motor neurons to both lower motor neurons, whereas the face below the forehead is unilaterally innervated, so that if you have a lesion of the upper motor neuron of, say, the right side, you will still get symmetrical motion of the forehead, but you'll lose the movement of the right lower portion of the face. When you have lower motor neuron disease, you lose the movement of the entire face on that side. So it's important to remember that fact. So facial nerve, very important nerve running all the muscles of the face. The eighth cranial nerve has two components, an acoustic component for hearing and also a vestibular component for balance. This is a pure special sensory nerve. We will test today the hearing component, but remember that the vestibular portion of the nerve is very important. It's the sensation of position for the head. We'll test that in more detail when we do coordination and balance. It's the precise ability of the vestibular function, however, to tell where our head is in space that allows us to fixate on a single point when our head moves. There are no other position sensors in the muscles of the head and neck. So when we run, we're able to keep our eyes focused on a single point, unlike the movies where you see a camera with somebody jogging and the picture jiggles. We don't do that because of the precision of the vestibular component to check any motion of the head in any plane and adjust our vision very precisely. So that's a very important part of the vestibular portion. But let's check now the auditory portion of the eighth cranial nerve. So there's several ways to check hearing. Very quick, easy way is just a finger rub about 6 inches from the patient's ear and ask them to compare right to left. You hear that?
Yes.
Hear it here?
Yes.
Any difference between the two?
No.
Okay. Another way is to use a tuning fork. The frequencies of normal speech are between 500 and 2,000 hertz. We use a 512 tuning fork, and again, just compare right to left. Hear that?
Yes.
Hear it here?
Yes.
Any difference between the two?
No.
Okay. And that's a very accurate screen. The other screen you're doing throughout your exam is detecting the patient's ability to hear normal speech and conversation. If the patient is leaning towards you, seems to be lip reading, is obviously missing some of the content, then that suggests there's clearly a problem with hearing or speech perception. Another way to check hearing that does not go through the middle ear is to check bone conduction by placing a vibrating tuning fork in the midline of the head. This will communicate the sound waves directly to the cochlea and bypassing the middle ear. If there's damage to one cochlea or the other, we'll get asymmetric sensation, and the patient will lateralize the hearing to one ear or the other. You hear that?
Yes.
Is it louder in one ear than the other?
No.
Right in the middle. Okay, so that's important. So that's a good test to just check for the cochlear component without having to go through the ossicles and tympanic membrane and the middle ear. So that's the eighth cranial nerve. We'll do more of the vestibular function of that nerve when we get to coordination and balance.
Solo le hace una sola prueba, ¿no? Faltan las otras
We're now
dos.
going to test cranial nerves 9 and 10. They function together, and so we'll test them together. Cranial nerve 9, the glossopharyngeal nerve, has a sensory component on the pharynx. It provides sensation for swallowing, for normal swallowing, and also the 9 and 10 have a combined motor function for the muscles of the pharynx, again involved in speech, normal speech tones, and swallowing. We're actually examining these nerves when we're listening to a patient's speech. The avoidance of nasalized speech requires a proper function of the soft palate. If a patient is talking with nasalized speech like this, that suggests that the soft palate is not working properly and involves cranial nerves 9 and 10. To check the sensory component of cranial nerve 9, we'll stimulate the posterior pharynx. This oftentimes will trigger a reflex arc or the gag reflex. To check the motor component, we ask the patient to elevate the soft palate by saying ah as we examine in the mouth. So we'll do those two things and see about this pharyngeal motor function. So I want you to open your mouth wide and say ah. Okay, relax. So when he says ah, we see nice elevation of the uvula and the soft palate. indicating normal and symmetrical contraction of the muscles. If the uvula pulls to one side or the other, that indicates weakness of the contralateral pharyngeal muscles. We're now going to trigger that reflex arc, open wide, say ah. And when I touch the back of his throat, he has a nice reflex constriction of the muscles. That's the gag reflex. Remember, this can be very violent in some people, so warn them what you're doing ahead of time so it's not too much of a surprise to them. So cranial nerves 9 and 10 work together as the motor exams of the pharynx. Cranial nerve 9 also supplies the sensory component of taste on the posterior third of the tongue, and again, we don't usually test that. The vagus nerve, or the 10th cranial nerve, supplies the afferent sensation from all of the viscera in the chest and abdomen, as well as having a autonomic motor component to the viscera as well, but we do not check that in terms of our neurologic exam. It is important to keep that in mind when you're doing exams, however, of the chest and abdomen, because the vagus nerve is part of the operation of all of the visceral organs in the chest and abdomen. So glossopharyngeal nerve, cranial nerve 9, vagus nerve, cranial nerve 10, examination of the pharynx.
9 y 10 caminan juntos, ¿no? El examen es junto.
Cranial nerve 11 is the accessory nerve, and it's a motor nerve that supplies motor innervation for the trapezius muscle, the sternocleidomastoid, and several of the small muscles in the anterior portion of the neck. We check cranial nerve 11 by asking the patient to shrug his shoulders up. While he's doing that, I'm feeling the contraction of the trapezius muscle, also pulling down to check the strength of the trapezius muscle. We then have him turn his head a little bit to one side and then turn his head back, chin back towards me. When he's doing that, I can palpate the contraction here of the sternocleidomastoid muscle on this side. Turn this way and turn your head back towards me on this side, and palpate contraction of the sternocleidomastoid on the opposite side. So cranial nerve 11, the accessory nerve, is a pure motor nerve, mainly innervating for our purposes the trapezius and the sternocleidomastoid.
Es muy sencillo el examen del 11. Y por último, el hipogloso.
The 12th cranial nerve is the hypoglossal nerve that provides motor innervation to the tongue. The tongue is a large muscular structure, obviously very important for swallowing and speech. So we're going to have the patient gently open his mouth, and we're going to inspect the tongue. It's important to look for symmetry of the tongue. If there's any wasting of the muscles, it suggests denervation. So open, gently protrude the tongue. Okay. It's very frequent, as you can see here, to see some fasciculation in the tongue, just the firing of individual motor groups. That's perfectly normal in the tongue. So stick the tongue straight out, all the way out as far as you can. Okay. Go ahead and relax. So when the tongue protrudes, we want it to protrude right in the midline. The muscles in the tongue that contract actually pull the tongue towards the center. So if one of those muscles is weak, let's say this muscle is weak, we're going to continue to contract on the other side. The tongue will deviate towards the weak side. So when the tongue deviates to the right, the ipsilateral muscles on the right side of the tongue are those that are weak. We can check the strength of the tongue to each side by having the patient push his tongue against his cheek, push out here, and have him resist your motion. Push on the other side, resist the motion. Again, that just checks the strength when he's pushing to right or left. When he's pushing towards the left side, it's actually the right side of the tongue muscles that are contracting to push the tongue, to pull the tongue actually across the midline. So, cranial nerve 12, the hypoglossal nerve, the motor nerves of the tongue, very important for speech and swallowing.
Bueno, ahí tienen los 12 nervios.